At the outset, I request our city branch president, Dr. Munian, to offer his presidential address.
Good evening, sir. On behalf of IAC City Branch, Puthukkottai, I welcoming moderator, speakers, and our academic chairman and delegates for the online webinar conducted by the Puthukkottai Bhudhan, which is a 28th episode of second edition on the topic of liver transplant and incidental surgeries. I would like to deliver a special address on liver transplantation and incidental surgeries. Would likely focus on the advancing patient care, promoting medical innovations, and addressing the healthcare disparities. Here there is some outlines about the liver transplant and incidental surgeries. What are the key points in liver transplant is improving access to liver transplantations, increasing awareness about organ donations, streaming the transplant process, and expanding the access to the undeserved populations. Advancement in liver transplant surgeries, like discussing the latest techniques such as living donor transplants and split liver transplants and their benefits. Incidental surgeries in liver transplant, like exploring the role of incidental surgeries like splenectomy, vascular reconstruction, and improving patient outcomes. Healthcare policy and reforms, addressing the policy initiatives that support organ transplantations, that support organ donation and transplantation in healthcare equity. What are the potential initiatives for liver transplant is financial support is the main problem for liver transplantations. The another one is research and development, investing in research and to improve the transplant outcomes, develop new technologies and increase the organ donation rates. Public awareness, launching public awareness campaigns to promote organ donation and educate the people about the importance of the liver health. In conclusions, the address on the liver transplant and incidental surgeries would emphasize the need for continued innovations, improved access, and equitable healthcare policy to enhance the patient outcomes and save lives. By working together, we can make a significant impact on the lives of the affected by liver disease. Thank you, sir.
Thank you, Mr. President. Now I request our Secretary, Dr. Kannan, to offer his Secretary report.
Good evening all. I am Dr. Kannan, Secretary, IAC Puthukkottai Branch. Successfully, we are conducting 20th webinar of second edition of Puthukkottai Bhudhan today. Today, our topic is liver transplant, incidental surgeries. I welcome all our eminent speakers to our webinar. Last week, 28th May, we have conducted 19th webinar of Puthukkottai Bhudhan, second edition successfully. Last week, our topic was labor pain relief. We have divided the topic into 3 subtopics. First one is neurogrid of labor pain. Second one is labor pain relief. Third one is complications in labor pain relief. Our moderator was Dr. Anju Griwal, Professor and Head, AIMS, Bathinda, Punjab. First subtopic, neurogrid of labor pain, was done by Dr. N. Rasmita, Fellow in Obstetric Anesthesia, birth rate by Rainbow Hospitals, Hyderabad, Telangana. Second subtopic, labor pain relief, was done by Dr. Silpa. She is consultant, birth rate by Rainbow Hospitals, Hyderabad, Telangana. Third subtopic, complications in labor pain relief. This topic was done by Dr. Sailaja, senior consultant, CAT Hospital, Hyderabad, Telangana. Last week, 870 delegates have attended our webinar. And one more thing, and the important one, we are going to conduct workshop on USG guided nerve blocks on June 14 and CME on June 15. I welcome all the delegates to register our CME and workshop. I thank our academic chairman, Dr. Veena Sundaram sir, for his kind support. Welcome and thank you all.
Thank you, Mr. Secretary. Now, in the thematic address, it is my duty to introduce the faculty to the audience. Routinely, we have audience ranging from 870 to 1000. So this time we expect it to cross 1000. And today we have the youngest faculty by name Dr. Greeshma. So Dr. Greeshma, we have marked her as DIPNB postgraduate, but it was fixed in the month of February. Even in the February, they have fixed this program, but the slot was I was able to give it only in the month of June. So Dr. Greeshma native is Kerala. She is a distinguished faculty because her native is Kerala. Her undergraduation is from Karnataka and post graduation is from Mumbai. So this is the peculiarity of her. Even during her post graduation, she has crossed 3 states, and she has that interest. After applying for Pudhukkottai Budhan, she passed her DPNB because the examiners came to know that she was invited as a faculty for Pudhukkottai Budhan. So that is automatic. That is automatic qualification for DPNB. So she has crossed that, and we congratulate her profusely for that. So she is interested in dancing, cooking, and music. So nowadays it is very difficult to see ladies cooking. So she says her interest is in cooking, but whether she will be seeing others cooking or she will cook, I don't know. But she is interested in that. So we welcome the youngest faculty, Dr. Greeshma, to deliver the lecture here. And she will be followed by the Bollywood hero Aditya Prabudesai. And Aditya Prabudesai was the main anchor in fixing this program. See, he literally shouted at me, "Why you are not calling us?" So he has given a lot of justification also. But the only point is my WhatsApp got stuck at that particular point of time. I could not retrieve his number, and at least his name, it should be like Prabhu. Then I can easily recollect. But Aditya Anil Prabudesai was very difficult to recollect. Even then, I was trying with many people in Mumbai. But Mumbai is not a Tanjavur, like as our Pudhukkottai. Only handful of anesthesiologists are there. Those says they say, "Sir, we know Aditya is only Surya, so he's a Surya Bhagwan. We don't know who is Aditya Anil Prabhudesai." It was very difficult. Then again, he has messaged me what is happening to our program. So this sort of a perseverance keeps us going. I really congratulate him profusely and thank him. See, he has not left it just like that. He realized that wantonly we will not be doing like that because we are also academically inclined. So persistently he was asking. So with his DP, now he looks very simple. In the DP, he will be real Bollywood hero. So I thought some hero is going to address, and he is from Maharashtra, but he is dealt, that is the liver transplant training he acquired in Kolkata, so West Bengal. So as Greeshma is from Kerala, Karnataka, this thing Mumbai, Aditya is from Mumbai to Kolkata. Again, he is in Mumbai and he is interested in liver transplant and pediatric anesthesiology and ultrasound guided nerve blocks. And more than this clinical skills, he is interested in teaching. And the thing is, he is a freestyle artist. That is, he used to paint. So I think we can request him at his leisure to paint a hero or heroine so that we will also know. Or even that hero, heroine may be anesthesiologist. He can select one anesthesiologist and he can paint. You paint Dr. Ujjwalraj, a senior hero. So you paint him and we will see how is it. Then he will be followed by Dr. Prajwala Kausik. So Prajwala Kausik is what she thought when these people are from Kerala to Maharashtra, Maharashtra to Calcutta. So what she did, she is from Karnataka to Mumbai. So she is also having 2 states. He is brought up in Bangalore. He has done her undergraduation is MS Ramaya Medical College. So you know MS Ramaya Medical College is one of the prestigious medical colleges across the country. Why I am saying that? My son is pursuing MD radiology there. So it is the best college available in the country. So she did her major training in anesthesia, liver transplant in KEM hospital. And there she got attracted and she has done liver transplant fellowship in Medanta Medicity. Now she is in Kokilaben hospital, now in Mumbai. And the best part is, see her stature. She's a great athlete. Whatever sports you say, she has played it. So he has represented school and college in badminton, basketball, volleyball. That is representation. But she has won the national competition in Karnataka throwball team. So she is good at throwing. So be careful when you are moving with her. Don't be close to her. She will throw at any point of time. And not only this, she is interested in Carnatic classical music. And she has represented her college in music and drama. So with that, she is not going to stop. So she is interested in trekking. So that also she used to do. So it is surprising that a female is exhibiting such a multi-talented figure in anesthesiology. So now we were confused when these multilingual, multi-state people are there. Who can moderate these great people? So we have found out Dr. Ujjwalraj Dudhedia. She has crossed 4 states. So he has done his schooling in 3 states. And from Madhya Pradesh to Mumbai, he has moved. So he is from Madhya Pradesh to Maharashtra. So this is a peculiar thing that people from 3 hospitals are participating because Gleneagles Hospital, Aditya Prabudesai, and Kokilaben Dhirubhai Ambani is Prajwala, Hiranandani is from Greeshma and Ujjwalraj sir. So this is a great thing that Puthukkottai Bhudhan has exhibited these faculty to the general audience. And Dr. Ujjwalraj sir is a pain specialist. He is interested in pain relief. He was the general secretary of Association of Regional Anesthesia India. So that is a great post. So he was the secretary, and naturally his areas of interest are regional anesthesia. Once she is interested in regional anesthesia, automatically it is obstetric anesthesia, and naturally he is interested in liver transplant. That is the reason why he can moderate the whole people, and he can manage acute and chronic pain. So acute pain by narcotics he will manage. By chronic pain, how he is managing? By singing. He is a good singer. He is a good singer. So by singing, sometimes he anesthetizes, sometimes he produces pain relief. And we have to see how he is going to tackle these 3 great people. And as a dean of Government Stanley Hospital, which is the only government hospital in Tamil Nadu, which was taking up regional liver transplant, I have seen how difficult it is. 3 teams will be changing. We were not doing the live liver transplant. We were doing only cadaveric liver transplant. At that time, this rotam, what Greeshma is going to describe, was introduced in the government hospital. So I have seen, and whenever liver transplant is posted, I revived the program. I myself will appear in the theater whenever liver transplant is posted. So in the 11 months, we have done 8 transplants. Same way, whenever a valve replacement is posted, I will go there because these are all the things which we have not seen in Tanjavur during our post graduation in Tanjavur. So I exploited the opportunity. That is the reason why I can talk confidently to Ujjwalraj sir, Aditya, or Prajwala, or Greeshma, or else I will be fumbling what is a liver transplant. Even the first arterial cannulation, they could not make the anesthetist. I have done that. Then the visiting surgeon asked me, sir, we were informed that you are dean of this medical college. How you are doing arterial cannulation? I said, a year back, I was doing this as a routine. Oh, that was my job. That I am anesthesiologist. Then that sort of a credit anesthesiologist has. So I am very happy, and now I request Ujjwal Raj sir to take over the session and to conduct it. Thank you, sir. Sir, you are muted.
Yeah, yeah. Thank you so much, sir. Thank you for your team. Thank you to the ISA Pudukkottai for inviting us and having us here on a very interesting topic about liver transplant and incidental surgeries. Let's move without wasting much of the time. Let's move on to the specific topics, and I'm sure you'll be while we take you through this journey, you will have you'll be enlightened with some interesting facts and figures, and that would definitely churn your mind into different questions. We'll be open to questions at the end of the session, but we also have a basket of questionnaires for you as a homework, which you can just take a snapshot. We'll be displaying it on the screen, and you can take a snapshot and solve it at your leisurely time and see how the webinar has helped you. So let's welcome Dr. Greeshma Somnath for the topic viscoelastic testing, which is TEG and ROTEN.
Thank you, sir. Good evening, everyone, respected teachers and friends. So my topic of discussion today is viscoelastic testing, focusing on TEG and ROTEM. So to start with, traditional coagulation tests are mostly the prothrombin time, in, INR, APTT, and serum fibrinogen. These tests are extremely tedious and require a central laboratory setup to do, and it takes a lot of time for the results to come. So nowadays we prefer point of care coagulation testing, which rapidly gives the coagulation status of the patient. And the most common test what we prefer is the TEG, which is thromboelastography, and rotational elastometry, which is ROTEM. So the principle behind this test is viscoelastic hemostasis, and this was first described by Dr. Helmut Hartet in 1948. So these tests particularly help guide us in resuscitation and blood product transfusion. So just a brief description of the coagulation cascade. So in normally the hemostasis is basically divided into two, primary and the secondary hemostasis. So primary hemostasis occurs when there's a vessel injury and the endothelin induces a platelet plug formation to prevent bleeding. So, and that is primary hemostasis. And the secondary hemostasis includes the extrinsic and intrinsic pathway, followed by fibrinolysis. So the extrinsic pathway usually happens when there's a trauma. There is the release of tissue factor, which activates factor 7 and then factor 10, getting into the common pathway of coagulation. And intrinsic factor occurs especially when there is a negatively charged substance, a damaged surface like a subendothelial tissue, subendothelial collagen, which is negatively charged, causes the activation of multiple clotting factors like the 12, 11, 9, and 10. And commonly, both the extrinsic and intrinsic pathway enters the common pathway, and it activates factor 2, which is the prothrombin, to activated thrombin, which further activates fibrinogen to fibrin, which along with the platelet plug, which was formed in the primary hemostasis, completes the process of clot formation. And then for all the clots which are formed, body has a natural mechanism to lyse them, so which is called the fibrinolysis. So for fibrinolysis, it is the plasminogen which is converted into plasmin by the tissue plasminogen activator, and this plasmin breaks down the fibrin into fibrin degradation products. So this is in general regarding, in short, regarding the coagulation cascade. So coming to viscoelastic hemostatic assays. So blood is a viscoelastic substance. So as it clots, the viscosity increases and the blood becomes more elastic. This property is used for these tests. So the sample we take for this is whole blood in a blue top vacutainer, which contains citrate. So this is the diagrammatic representation of which consists of a cup and a pin, which is suspended by a torsion wire. And the blood is taken in the cup or the cuvette, and it undergoes clockwise and anti-clockwise rotation. And this motion, this rotational motion, causes a torque which moves the pin, and this movements are transduced to form the graphical representation. So the difference between the TEG and the ROTEM is, in TEG, it is the cup which rotates by about 4 degrees, whereas in ROTEM, it is the pin which rotates and the cup remains still. Coming to TEG, this gives the whole blood is used as a sample, and this gives the real-time analysis of the complete coagulation process. So it is rapid and it can be done blood side. So this helps in a goal-directed therapy. So this is a graph, and there are various parameters which are derived from TEG. So the first one is R time, which is the reaction time. The reaction time is the time taken from the initiation of the test up to the initial clot formation. And it ranges from 5 to 10 minutes. And it is the controlling pathway is mainly the clotting factors. So any change in the clotting factors can cause increase in R value. And the next parameter is the K time, which is called kinetics time. So this is the time required for tracing or required to reach 20 mm amplitude. So So the time required to reach the 20 mm amplitude is called K time, and fibrinogen is the main factor which determines the K time, and the angle formed by the baseline and the tangent drawn to the deviation is called the alpha angle, which gives the rate of the clot formation. And this is also determined by the fibrinogen. So the x-axis is basically the time, and the y-axis is the rate, the clot amplitude of clot formation in millimeters. And the next parameter is maximum amplitude, which is the highest or the maximum highest amplitude of the graph. So this gives the greatest clot strength that is achieved. And platelets and fibrinogen are the ones which determine the maximum amplitude. Coming to LY30, which is lysis percent at 30 minutes. This once the fibrinolysis starts, the percent of decrease from the maximum amplitude is called the lysis percent at 30 minutes, after 30 minutes. So this indicates fibrinolysis. So according to this, we determine what all products have to be given. So there are different types of TEGs based on the activators used. So native TEG is where there is no activator, which gives a idea of the baseline blood coagulation. Kaolin is when kaolin is used as the activator, which activates the intrinsic pathway and makes the process faster. Kaolin TEG with tissue factor activates intrinsic and extrinsic, giving a rapid assessment. And if the blood sample contains heparin, then kaolin with heparinase is preferred. And from this, we can know we can assess the heparin reversal on blood coagulation. And TEG functional fibrinogen is tissue factor with abscessimab. Here, the abscessimab inhibits the platelets. So we can solely know the participation of fibrinogen in clot formation. These are few abnormal examples of TEG. So first of all, this is a normal TEG, which shows a normal R, K, maximum amplitude and angle. And this can be compared to a brandy tumbler. And the next graph is which shows increased R time and K to reach 20 mm amplitude. And but the MA, when compared to the normal, is reduced. And the angle is also reduced. So this indicates that the patient is deficient of clotting factors, which can be in hemophilia or the patient is on anticoagulants. So, and the next graph, the third graph, it shows R value is normal, but K is prolonged and the maximum amplitude is reduced. So this shows maximum amplitude is determined by platelets. So it's mostly the patient is either on platelet blockers or patient is thrombocytopenia. And the fourth graph shows R value, increased R value, and the maximum amplitude, the trend of the maximum amplitude keeps on decreasing. And the lysis, the percentage of lysis at 30 minutes is also increased. It is more than 8%. So it indicates fibrinolysis or the presence of a fibrinolytic drug. And such this graph can be compared to an upside down martini glass. In such patients, we have to give an antifibrinolytic like tranexamic acid. The next graph shows a shortened R time and decreased K time and a maximum amplitude. The amplitude is very high and the angle has also increased. So that means it takes the shortest time to form a clot. The blood sample clots fast. So the patient is in a hypercoagulable state. And the next graph shows similar short R time and K time, a wide angle, and maximum amplitude is high, but followed by the lysis at 30 minutes is the percent is very high. So this is hypercoagulability followed by secondary fibrinolysis. And the next graph shows an increased R time, increased K time, decreased angle and decreased amplitude. So that means the patient takes a lot of time to, the blood takes a lot of time to clot, showing that it's a hypocoagulable state. This is the entire parameters and its blood products and the treatment required in as a summary. So the normal R time is 5 to 10 minutes, and as coagulation factors are responsible, the treatment that is to be given is FFPs. And K time, the maximum time, the normal value is 1 to 3 minutes. So cryoprecipitate is given as fibrinogen is the problematic. Next is alpha angle, 50, which is 50 to 70 degrees. Fibrinogen is determines the alpha angle, so cryoprecipitate is preferred. And maximum amplitude, range of 50 to 70 mm, since it dependent on the platelet transfusion has to be done. And lysis at 30 minutes, the percent lysis, if the normal value is 0 to 8%, so which shows that excess fibrinolysis. So we have to give an antifibrinolytic like tranexamic acid or aminocaproic acid. TEG 5000 is an example of the TEG system, and which follows the sample cup. Sample is kept in a cup with pin pattern, and here the rotation of the cup followed by the rotation of the pin determines the clot strength. Now the latest model of TEG is the TEG 6S. Here, instead of using a cup and pin, we use cartridges. So there are two cartridges that we use, which is a global hemostatic cartridge and a platelet mapping cartridge, which uses multiple activators to activate the intrinsic and the extrinsic pathway. And values can be determined in like 10 minutes. So multiple graphs superimposed assays are seen. Next, coming to ROTEM, rotational thromboelastometry. This is also a fast and reliable process, point of care testing. Here, lesser amount of blood is only required, around 0.3 ml, and it is heated to 37 degrees in a cup, in a cuvette, and there is a pin which is suspended, and the pin has been attached with a mirror, which reflects the light that comes from an LED source, and this light which is reflected is detected by a photodetector, and then the data is processed to give the ROTEM graph. So this is also used for targeted therapeutic interventions. So this is a normal graph of ROTEM, which has time on the x-axis and amplitude of clot firmness in mm in the y-axis. So the first is clotting time. So it is the time required to reach, that's from the start of the test to reach 2 mm amplitude. And this shows that the fibrinogen has acted and clotting has begun. And the next is clot formation time, which denotes clot amplification, the time from 2 mm to 20 mm. And this estimates the velocity of the clot formation. Alpha angle is the angle formed by the baseline and the tangent to the deviation. And this also tells us the velocity of clot formation. A5 and A10 are the amplitudes at 5 and 10 minutes respectively. And MCF is the maximum, similar to maximum amplitude in TEG, and maximum clot firmness is the maximum amplitude of the graph in ROTEM, and it gives us the mechanical strength of the clot, and is determined by platelets and fibrin. LI, lysis index 30 at 30 minutes and 60 minutes, gives us the idea of lysis from after attaining MCF. So this is mediated by, this shows that fibrinolysis and platelet mediated clot retraction. And ROTEM is also of different types, depending on the activators. NATEM, which does not have an activator, showing native blood coagulation. INTEM uses phospholipid and ellagic acid. So ellagic acid is the intrinsic pathway activator. So, and EXTEM uses tissue factor to test the extrinsic pathway. And HEPTEM is when heparinase is also used, similar to TEG, and it inactivates heparin, and heparin reversal can be estimated. Next is APTEM, is where aprotinin is used as the activator along with tissue factor. It inhibits the fibrinolysis. So we can test the effect of fibrinolysis in the sample. Next is FIPTEM, which uses cytochalasin D, which is a platelet inhibitor. So this also gives the sole strength, contribution of the fibrinogen to clot formation. So this is the summarized version of ROTEM and the parameters. So the applications of viscoelastic assays is mainly for cardiac surgeries. So cardiac surgeries where the source of bleeding suppose is unknown, like if it's a surgical cause or if it's due to any coagulopathy or reversal of heparin, all these can be determined by using viscoelastic assays. Next, in liver transplantation, where cirrhotic liver is prone to a lot of coagulopathies, and there are large blood losses intraoperatively. They can be used to see the status, and treatment can be given. Transfusions can be done accordingly. In major trauma, the reduction in use of blood transfusions and associated mortality during the resuscitation can be checked by using viscoelastic assays. In obstetrics, used in PPH, where there is severe hemorrhage, it is used as a transfusion guide. And other disorders like hemophilia, because clotting factor deficiency can be determined. So this is in short regarding the transfusion, how viscoelastic assays are used as transfusion guide. In ROTEM, we consider CT first. Suppose if CT is prolonged, fibrinogen or clotting factors are deficient, so we have to give fresh frozen plasma or prothrombin concentrate. Suppose if CT is normal, the next factor we look for is MCF. So if MCF is low, then we have to go, it can be either due to fibrinogen or platelets. So to differentiate that, we do a FIPTEM. And if the FIPTEM, the platelets are inhibited in FIPTEM. So if the FIPTEM is low, that means patient is deficient of, patient is in hyperfibrinolysis. So we have to give cryoprecipitate. And then if FIPTEM is normal, that means platelets are inhibited, but still FIPTEM is normal. That means fibrin content is normal. So we have to administer the patient platelets. And if MCF is also normal, then the next we consider is Li30. So if Li30 is too high, it means the patient is in hyperfibrinolysis and we have to give tranexamic acid. Similarly, in TEG, R is considered. So if R time is increased, we have to give FFP and PCC. If that is normal, maximum amplitude is considered. And if that, to differentiate fibrinogen and platelet, we have to give a fibrinogen fraction or platelet mapping is done, and cryoprecipitate and platelets are given. And lysis 30 and 60 are too high, then we have to give an antifibrinolytic. So basically the difference is, the main difference is that viscoelastic can be done bedside with minimal transit time within 10 minutes. And it requires additional training, assurance, and maintenance. It's cost effective, and global assessment of clotting is possible. And it can help in as a transfusion guide. So to summarize, viscoelastic testing helps in the rapid assessment and transfusion therapy in major hemorrhages. It uses them. It helps in the significant reduction in transfusion requirements and helps in minimal resource utilization, cost, and transfusion associated morbidity. Thank you.
Thank you, Dr. Greeshma, for that wonderful, enlightening steps of coagulation cascade and methods to test them. We'll take on questions later on. Let's quickly move on to the next topic. I'll invite Dr. Aditya Prabudesai for his talk.
Good evening, everyone. I thank Dr. Meenakshi, sir, for this opportunity. And also, I thank Ujjwalraj, sir, for moderating this session. So the topic given to me is a cirrhotic patient posted for non-transplant surgeries. So it's a very common scenario in our clinical practice that a cirrhotic is posted for maybe a hernia surgery or a hemorrhoid surgery or any other surgery, and we keep on thinking how to proceed. So this is just a short review about the same. So the presence of cirrhosis in itself increases the risk of post-op mortality and increase in the length of stay by about 47% in the patients who are undergoing surgery. we need to understand that cirrhotics are at a rebalanced state of homeostasis, and anesthesia and surgery may tip the balance and deteriorate the liver function and pushing the patient into hepatocellular failure or criticalities of the liver disease. And hence, meticulous preparation for the case, including assessment and clinical observation, and carefully planning the anesthetic management and postoperative care is very important in such cases. So, liver in itself, when at problem, it decreases the metabolic function of the body, and hence the pharmacokinetics and dynamics along with the normal metabolism decreases. It causes hypoglycemia, decrease in lactate clearance, and other decompensations which we already know, like jaundice, hyperbilirubinemia, the varices because of portal hypertension, and ascites. It affects on the neurological system by decreasing the clearance of ammonia by causing irritability to start with, then narcolepsy and hepatic encephalopathy. Renal injury, whether it is pre-renal acute kidney injury or biliopathy because of the hyperbilirubinemia leading to ATN, or hepatorenal syndrome, which is the direct effect of the liver diseases on the renal system because of splanchnic vasodilatation, may precipitate and present to us with increased creatinine along with other electrolyte imbalances, which includes hyponatremia, hypomagnesemia, and hyperkalemia. The pulmonary effect of this hepatic system is mainly because of the ascites that reduces the FRC, along with which there could be hepatopulmonary syndrome, which are the formation of physiologic shunts, decreasing the oxygenation and tipping the ventilation oxygenation into a mismatch, or a portopulmonary hypertension, which is a basically increased pulmonary hypertension leading to right-sided or right ventricular defects. Coming to the cardiovascular system, whether it is the tachycardia and hyperdynamism of the liver disease, or cirrhotic cardiomyopathy, or simply increase in the QT interval and arrhythmias, hepatic illness has profound effect on the cardiovascular system. So and so forth. In a hematologic system, we usually subconsciously equate hepatic diseases is to bleeding diastasis and say that the patient would bleed. Let's discuss further in detail as a special topic about hematologics, what happens. But yes, in a same patient, there may be bleeding diastasis in the form of portal hypertension and upper GI bleed. And the patient at the same time may have portal venous thrombosis. So this is imbalanced coagulation or coagulopathy, which is present in the same patient. So what I mean to say and highlight is hepatic diseases have widespread defects and affection on the other organ systems. And hence, the goals of our preoperative assessment should be assess the type and the degree of liver dysfunction. What is the etiology and how even that etiology would affect different organ systems in that particular fashion. Also, assess the effect on the other organs. What type of surgery are we going ahead with? Whether it is low risk or a high risk surgery for even bleeding, because surgery in itself will have some inherent challenges and effects on the coagulation system. And considering all this, we need to assess that we should have good post-operative facilities for this high-risk patients, maybe in the form of ICUs or high deficiency units, that is HDUs. Coming to the clinical examination, when a patient is seen in the PAC clinic, we need to take the history. In the history, we should understand what is the severity and extent of the liver disease. Does the patient have any extrahepatic manifestation of chronic liver diseases? That means whether the patient has pedal edema, renal failure, or breathlessness and hepatopulmonary or portopulmonary hypertension, whether the patient is losing its consciousness and has been admitted prior with hepatic encephalopathy, or how is the electrolyte balance of the patient. So in short, we need to also understand is the patient is in the decompensated state or whether the patient is fairly recompensated. ACLF and ALF are the other two subsets. Let's not consider ALF because right now we are talking about the cirrhotics. So acute on chronic liver disease or acute on chronic liver failure is an entity which is identified by the hepatologist in the recent years, where a chronic liver failure or cirrhotics may tip and get into acute liver failure because of some insults that may be infective or because of constipation or because of precipitated because of the upper GI bleed. Now, apart from this, we may have to consider what are the specific considerations because of the etiology. The effect of alcohol, Wernicke's encephalopathy, or micronutrient deficiencies that patient may have. Patient may have had recurrent falls, or because of autoimmune hepatitis or hepatic disease, patient may be on a steroids. So what is the etiology and how the patient is being treated and what all the drugs are there in the pan for the patient. Apart from this, when we examine and when we get the patient inspected, palpated, percussed, and auscultated, we need to see what is the blood pressure. Usually, as I said, it's a hyperdynamic state with tachycardia, with peripheral vascular dilatation, and hence we will have lower systolic and diastolic pressures. Oxygenation is important. 98% or more is usual normal for a normal healthy adult. If it is decreased than 96, the antenna should be raised for hepatopulmonary syndrome and orthodeoxia, and hence the supine and sitting oxygenation should be checked. Inspection should be done for ascites, whether this ascites is causing respiratory compromise and patient is in breathlessness. Should this ascites be drained as a measure of therapy before taking the patient for the surgery? How much is the jaundice? So hyperbilirubinemia traditionally has been shown to affect the SA node and cause bradycardia, but in clinical practice, we rarely see it. Yet hyperbilirubinemia, whether it is direct or indirect, would give you a clue of etiology. If there is hemolysis going on and if the patient is in indirect hyperbilirubinemia, you may have to reserve adequate blood and assess what is the pre-operative hematocrit. Caput medusae, if they are present, it may pose great risk for surgical bleed and you would have to prepare yourself accordingly. If the patient is in high estrogenic state, the patient may have spider nevi. There, because of the high estrogenic state, you may expect DVTs, and hence you have to assess the calves, ask the patient accordingly the history for unmasking the DVTs, and be prepared intraoperatively also for such cases, whether you may have thrombosis in a cirrhotic patient and you may have to give prophylaxis for DVT in the form of Clexane in postoperative period. Gynecomastia, asterexis, and encephalopathy may unmask the hyperammonemia and hence the renal and brain affection. As I said, there is a large affection of hepatic diseases over the cardiovascular system. Let's see as a special mention. So increase in the cardiac output and compromised ventricular response to the stress. It leads to the cardiac abnormalities and repolarization abnormalities. Hyperdynamic circulation is an inherent pathophysiological progress of the cirrhosis, where there is low systemic vascular resistance because of nitric oxide and VEGF, which are secreted by the liver, and increase in the peripheral vasculogenesis. To counteract this and maintain the cardiac output, the heart is given stress in the form of increase in the heart rate because the cardiac output is dependent in such cases on increase in the heart rate. So chronotropic incompetence is seen, and hence it is because there is increase in the QT interval, and hence drugs which are affecting or increasing the QT or causing QT prolongation should be used cautiously. For example, ondansetron and paracetamol, which we commonly use in our clinical practice. Electrical disturbances may also be seen because of hypomagnesemia or hyponatremia or at times hyperkalemia. And hence this milieu is disrupted, causing dyssynchrony. Many of the times the patient may have comorbidities like diabetes, or the reason of cirrhosis may be non-alcoholic steatohepatitis, which is a metabolic syndrome, or nowadays a new term which has been introduced, that is MAFLD. In such cases, the risk for coronary artery diseases is increased, and patient may also have IHT as a background disease. Cirrhotic cardiomyopathy in itself is a diastolic abnormality which is caused because of the liver disease, and patient may present to us with grade 2, 3, or 4 diastolic dysfunction. During the surgery, if there is extravasation of fluid, or nowadays the third compartmental theory is out, but if the central venous return is low because of certain reason, patient has tendencies to go into left ventricular outflow obstruction, and this may pose a greater risk. In such cases, when the BP is low and heart rate is high, one needs to treat this with fluids and then beta blocker, although the blood pressure is low. This is one of the unique clinical scenarios where LVOTO is managed, and hence in the background we should have this possibility into mind when we are standing at the head end. So preoperative investigations, again depending on the kind of surgery, the risk involved, we have to get the full battery of tests done. Hematologically, the full counts, LFTs, RFTs, coagulation profile. And here I would make a special mention, as Dr. Greeshma has already explained to us, dynamic viscoelastic hemostasis assays are more important than one-time INRs and bleeding clotting times in nowadays. Coming to the cardiovascular system, specifically the ECG, transthoracic echocardiography are important. At times, if the surgical risk or the anesthesia risk or the extent of hepatic disease is warranting, we may have to go ahead with cardiopulmonary exercise testing, which may include DACs or TMTs. Coming to the respiratory, in some cases, we may have to analyze the arterial blood gas at room air, or we may have to take the patient to the OT, or in a closed circuit, give 100% oxygenation and unmask the hepatopulmonary syndrome, which is already present. Although chest X-ray is mandatory in all such cases to rule out any right hepatic hydrothorax or left pleural effusion, which may have etiology of tuberculosis as an isolated disease. Hepatic venous pressure gradient may be done in some cases with portal hypertension, but it is not routinely done. Now we are doing all such battery of tests, but what is its use? So we need to know the pattern of disease, and hence we will get this information from bilirubin, OTPT, and alkaline phosphatase. For a single marker, if the disease of liver is because of alcohol or drug induced, it may be GGT, which would be raised. While if it is isolated intoxication, GST would be raised. To judge the synthetic ability of the liver, serum albumin is very important, and more than that, the lesser half time is present with INR, and hence INR more than 1.3 may suggest a significant synthetic inability of the liver. So this is some hallmark of the LFTs which I have enumerated here, which may come as MCQs also in the competitive exams. Echo, as I have been giving the special mention of cardiac system. So echo would inform us ventricular functions and size, valvular function, pulmonary artery pressures, if there is any portal hypertension, portopulmonary hypertension, exclude any left ventricular outflow tract obstruction or pericardial effusion. And PASPs are very important to know whether the patient is fluid overloaded or no. Now, blunted chronotropy and inotropy may be present to this trace in the form. I mean to say that in case of increased stress under anesthesia, patient may not be able to give a tachycardia, and there would be a decrease in the blood pressure. Here we need to add vasopressors in the form of noradrenaline, and we should be ready for such clinical scenarios. To predict the perioperative risk factors, we have multiple scoring systems, out of which MELD and CTP are commonly used. But apart from this scoring system, there are patient-specific risk factors: age, gender, being male, preoperative in case of any infection, if the patient is of PBS, that is primary biliary cirrhosis, elevated creatinine and superimposed renal failure, obstructive pulmonary diseases, intraoperative hypotension, and already present ascites and upper GI bleed are certain patient-specific risk factors. While we come to the surgical factors, the high-risk surgery, they involve any abdominal surgeries, open cholecystectomies, cardiothoracic and trauma settings, again, emergency surgeries as an isolated risk factor, and if the patient is going for esophageal surgery. This pose increased risk in form of either increased translocation and spread of infection and postoperative sepsis, or coagulopathy and bleeding risks. So we all know about the modified Child-Tourette Park classification and CTP score. We define the patients into 3 categories as A, B, and C. Just remember this. We'll come to this clinical application of score shortly. Recently, when we counsel the patient, apart from the reversible and irreversible risk factors, sometimes we need to quantify the risk and tell the patient relatives in the form of percentages. In such cases, some scoring systems have been devised, and one of them is Mayo Clinic postoperative mortality risk, which gives risk of mortality in immediate post-op, 30 days and 60 days, where we can quantify the risk and objectively tell the relatives and the patient and make them understand the in depth in the layman's language how we can go about the present condition. Another such very important surgical risk score is vocal pain. Here again, post-operative mortality has been described as 30 days, 90 days, and 180 days. So when the case is an emergency cases, such scoring systems are very helpful so that we can quantify the risk and inform the relatives. Coming to the preoperative patients with liver diseases, when we are going ahead with the surgery and when we have to quantify or identify the risk factors, how to go about. If it is a case of acute liver injury or acute liver failure, please defer the case unless it is a transplant in itself, which is a curative surgery for ALI. If the patient is CTPA, now this is the clinical application of these scorings, or if the MELD score is less than 10, consider proceeding with caution. So we need to take meticulous history, be prepared for intraoperative considerations and postoperative monitoring. This risk increases a little further if the patient is CTPB or within the MELD of 10 to 15. Again, pre-op optimization is required in such cases, and postoperative special care is also required. While in case of CTP-C or MELD more than 15, we may have to consider an alternative arrangement or non-invasive procedure, which may be the answer or the curative option which is given. We may have to defer and cancel the orthodox surgery. For example, if there is a choledochal cyst, at times we may have to go using ultrasound, endoscopic ultrasonography, and get a choledochogastrostomy done rather than a orthodox surgery done. So it's an intraluminal non-invasive hepatology-driven procedure which can be done, avoiding the open abdominal surgeries. Coming to specific surgeries, now most of these patients, they may have to go ahead with cholecystectomies. Now, mortality risk and the rates who undergo open cholecystectomy is around 23 to 50%. May not happen inside the OT itself, but postoperative mortality increases in such cases. Now, that is, in cardiac surgery, it is up to 16 to 31% more than the other non-liver patients. Laparotomy for trauma, mind you, this is an emergency setting. The risk may increase up to 45%, and esophageal surgery, it may increase from 17 to 26%. Patients with coagulopathy and CTP-C are at even higher risk in all such cases. So this is the heads up for what are the high-risk surgeries. The bleeding risk stratification in such patients, we may have to go ahead with, and we can classify certain procedures as low risk for bleeding. For example, insertion of CVC or peripheral lines, coronary angioplasty, gastrointestinal endoscopies, or transesophageal echocardiographies, and diagnostic disease procedures like bronchoscopies. But when the nature of surgery increases from the diagnostic to therapeutic cases, the risk of bleeding increases 1.5 times. If there is even a biopsy, whether it is liver or renal biopsy or any other thing, tumor ablation, whether it is CT guided or as MR guided, transjugular intrahepatic portosystemic shunt, that is TIPS, endoscopic polypectomies, dental extractions, or gastrostomy placements, all these surgeries, even if looked at as similar as smaller cases, may go ahead as a higher risk for bleeding. So coagulation, Dr. Greeshma has already explained the traditional way of intrinsic and extrinsic pathways. I would like to make a special mention, and this has been questioned in all postgraduate exams since 2015, that what is a new model of coagulation. So is coagulation pathway correlated in vivo, and is the presentation enough? No. So that's why there has been development of cell-based model. Thanks to Ronald Ross, we have good videos. So let's see these two videos.
Coagulation progresses in three phases: initiation, amplification, and propagation. Now let's see it in action. Initiation of thrombus formation typically begins with the exposure of tissue factor, either as a result of vascular injury or when it is expressed on the surface of activated monocytes. Initiation of coagulation begins when the tissue factor comes into contact with activated factor 7. This complex is known as the 10-ACE complex. This complex then activates factor 10. Activated factor 10 then encounters activated factor 5. This complex is known as the prothrombinase complex. This complex causes the activation of factor 2, which is also called prothrombin. This last step yields a small amount of the active enzyme called thrombin or activated factor 2. Now let's explore the amplification and propagation phases of coagulation. Platelets adhere and aggregate when surface glycoproteins come in contact with von Willebrand factors found on nearby endothelial cells. After platelets are activated, either by soluble or cell surface triggers, they undergo a shape change, which involves a rearrangement of the phospholipids comprising their membrane. Coagulation factors associated with the intrinsic pathway are brought into close association on the platelet membrane and result in the large amounts of thrombin produced in the propagation phase. The 10-ACE complex, composed of activated factors 8 and 9, activates coagulation factor 10. Activated factor 10 then forms the prothrombinase complex with activated factor 5. The prothrombinase complex is a very efficient catalyst for the formation of thrombin from prothrombin. Now let's explore the amplification.
So that was an attempt to make this slide and this presentation a little more interesting and interacting. So in cirrhosis, the coagulation is rebalanced. It's not always that the liver patient will bleed or may have a lot of bleeding. And hence, what is this rebalance? Now, there is quantitative and qualitative defect of platelet. So there is thrombocytopenia because of bone marrow affection or because of the disease of chronic disease. There may be decrease in thrombopoietin, which is a stimulus to the bone marrow secreted through the liver. And there may be splenic sequestration because of portal hypertension. All these conditions, they decrease the quantity of the platelet and also deform them and make them qualitatively disabled. At the same time, the von Willebrand factor, which is secreted from the endothelium, is increased because it's a chronic inflammatory state because of the liver disease, and there is decreased level of ADAM-ST13. Now, all of this, although there is qualitatively defective and less platelets, there is higher chances of platelets to get adherent, amplify, and then propagate into the clot. And hence, this rebalances form at the primary hemostasis. At secondary hemostasis, the coagulation, the carboxylation dependent factors which are carboxylated in the liver like 2, 7, 9, 10 and 11 may be decreased because of vitamin K deficiency. There may be dysfibrinogenemia. At the same time, there is decrease in the procoagulation and there is decrease in the anticoagulation as well. There is decrease in the level of protein C, S, antithrombin, alpha-2 macroglobulin, and heparin cofactor 2. Again, this is getting the coagulation to a rebalanced state. In fibrinolysis, that is the age of the clot, there is low level of alpha-2 antiplasmin, factor 13, and there is elevation of tissue plasminogen activator. At the same time, there is low levels of plasminogen. In short, the clot which is formed may live longer, and hence the clotting can be achieved in such state, and hence again rebalancing this coagulation. So the motive of this slide is to tell you that liver disease does not equate to bleeding. There may be increased procoagulation, there may be thrombosis, there may be DVT in the same patient who is with liver disease. So coming to the main gist of this particular presentation, administration of anesthesia. So here we have certain consideration. We need to minimize the insult to liver and kidneys, maintain the oxygen demand supply relationship in liver and all other organs. We have to maintain the peripheral vascular resistance and hence the diastole, and thus ventilation and perfusion to the end organs should be maintained. We have to avoid hypotension, hypoproteinemia, and hypoxemia and maintain the perfusion. Fluid balance with balanced fluids, specifically acetated balanced fluids rather than the lactated fluids. And hence we need to choose the anesthetic agent also, which would be enough getting metabolized in the system. Intraoperative monitoring, the routine ones that we always do as ASA2 and 3 monitors, that is NIBP, ETCO2, urine output, ECG, which may be 12-lead ECG with 2 leads, that is lead 2 and lead 5 on the monitor, continuous SpO2, and neuromuscular stimulation monitors. In case of longer and extensive surgery with increased risks of hemorrhage, we may have to see the CVP. Invasive blood pressure, that is arterial blood pressure monitoring, we may have to club both these two and get into Edward 1000 or flow track or pulse contour monitors. We may need frequent ABGs to assess the electrolytes, blood sugars, and TEG and ROTAM to depict the risk of coagulation. Transesophageal echocardiography is a new thing in major surgeries, are being used commonly by the anesthesiologist. So intraoperatively considerations, we have to get large bore access, if not a central venal line. In case of ascites, there is delayed gastric emptying and increased risk of aspiration, and hence we may have to go for RSI. Administration of colloids as solution in form of 5% albumin instead of starches, which may increase the coagulopathy. Intraoperative coagulation homeostasis should be maintained, and we may have to transfuse some blood products depending on TEG and ROTAM. Pharmacology, These are the questions that they may ask as MCQ. So induction agent of choice is propofol, and the drug induction agent that we have to avoid is benzodiazepine. Neuromuscular blockers, choice is atracurium or cisatracurium because of Hoffman elimination. Opioids, we may use short-acting, that is fentanyl and remifentanil, very effectively. We may add magnesium as an agent of anesthesia and also an supplement for hypomagnesemia. Dexmedetomidine is worked very effectively if we have to give TIVA. Inhalational agents, isoflurane would give the hemodynamic stability, or sevoflurane will give quickness, and hence the reversal would be better. Recent trend, we are using TIVA in case of all such hepatic surgeries very effectively. So this was one of the paper. I know this is a PG session, but this was very significant one, which was showing comparison of post-op liver function if used inhalational versus TIVA, and they have said TIVA has been used very effectively and safely in all such cases. Regional anesthesia, again, since the balance is modified in case of coagulopathy, we can consider regional anesthesia as a safer choice because surgery-induced stress responses and immune responses have been attenuated by regional anesthesia, and stressful condition is basically made easier. Epidural anesthesia, if used, is an excellent pain relief and may reduce postoperative mortality, and regional anesthesia in lower doses can be given safely. So with coagulopathy, as I said, yes, it is a rebalanced state. We can use it safely. ASRA guidelines at present are based on APTT, PT-INR, and the quantity of the liver, of the platelets, but they are based on the anticoagulation or the drug-induced anticoagulation. Can we follow the same? We take it with a pinch of salt. ASRA guidelines cannot be used in hepatic patient, and this is the area of discussion. But ultrasonography guided specific nerve blocks can be used very safely in all the cirrhotics, and we can get away with regional anesthesia without the need of using general anesthesia. Postoperative concerns, one is precipitation of the liver decompensation, increased risk of postoperative hepatic failure and tipping the balance. Here the scores are very important. If there is introduction of infection iatrogenically or hospital acquired, risk of bleeding, there could be poor wound healing in post-op areas, and there could be renal dysfunction because of the fluid disbalance. Postoperative analgesia, IV PCA in the form of fentanyl along with regional nerve blocks can be used very effectively. It is useful. Regional anesthesia is very useful in reducing the need of systemic analgesia and hence their side effects. NSAID is a big no-no because they would act on GI and also platelets and increase the nephrotoxicity. Acetaminophen is not contraindicated, but the dosage should be adequately modified to be given in a liver patient. Here, post-operative care, we need to give the care in HDUs or ICUs, at least in the first 24 hours for type C and B of CTP score patients. We have to monitor them effectively for development of any complication, and we have to avoid hepato and nephrotoxic drugs. Oral feeding is shown to increase the rehabilitation, shown to decrease the rehabilitation time and increase or fasten the recovery, and hence should be started as early as possible. Regular blood checks, including LFT, RFT, and sugars should be done in this period, and any decline in liver or renal failure may indicate sepsis, and broad spectrum antibiotics should be applied. Post-op jaundice is a special topic. The incidence, although it is less than 1%, it is because of overproduction or under-excretion of bilirubin, and it may show extrahepatic obstruction. It is mild if it is the bilirubin is less than 4 and severe if the bilirubin is more than 4. These are enumerated reasons. Immediate post-op, there may be hemolysis, infection, bile duct injury or obstruction, or any resurgence of viral hepatitis that may happen in this period, or it may be also because of blood transfusion. Delayed, which is more than 3 weeks, it may be because of total parenteral nutrition if the patient is on, or maybe because of the drugs. Thank you.
Thank you, Dr. Aditya, for creating a nice roadmap for evaluation of the liver patient coming for a non-liver surgery or non-transplant surgery. What I liked in your presentation is that you initially targeted the main physiological insult in any liver patient, which gives us the direction as to what area we should be targeting when we are assessing the patient for planning the anesthetic management. So we quickly move on to next topic. I'll invite Dr. Prajwala to take her topic, and her topic is post-transplant patient for non-transplant surgery. So we understood the coagulation system, we understood the intricacies of liver disease on a patient and to how to plan anesthesia. Now from there, we see a patient who was in past a liver patient has received a transplant. Now Dr. Prajwala will enlighten us whether this patient should be taken as a normal patient or poses a different challenges from our thought. Over to you, Dr. Prajwala.
Yeah, good evening, everybody. I hope I'm audible.
Yeah, you are audible. Just get your presentation into slideshow.
So the question by Dr.
Yeah, so
Rajgopalan
Dr.
is
Muthukumar
what
Rajgopalan wants to ask whether risk of spinal and epidural hematoma in these cirrhotic patient is severe, or and how safe is to go for central neuraxial anesthesia in these patients.
Right. So in such cases, we need to understand if the INR is more than 1.3, we have to consider the risk of deranged synthesis of liver proteins and coagulopathy. So in such cases, we may have to run a TEG or a ROTEM. Here, if the ROTEM and TEG is of use to show how is the in vivo coagulation, and that's how we can assess the risk of hematoma formation in a closed space. We cannot simply state that the low platelets and increased INR would give a risk of would be the risk factor for the central neuraxial anesthesia. The platelet count in such cases are considered 80,000 and more, and that is also replicated from the ASRA guidelines. We don't have such guidelines specified for cirrhotic patients. The studies needs to be done, and we may come up in future. So that's the area of discussion. But yes, there have been isolated case reports where with normal TEG and ROTEM, people have gone ahead and done central neuraxial anesthesia offered to the patient, and patient has done fine.
Yeah. So in nutshell, if I have to summarize, one is the clinical scenario, pro and con of RA versus GA, and availability of TEG. A single marker or single investigation will not be able to give you the directives whether to go ahead with regional or not, apart from TEG or ROTEM. Okay. I think Dr. Prajwala is ready now. And we move on to, shall we take you, Dr. Prajwala?
Yes, sir.
Okay.
Yeah, good evening, everyone. At the outset, I would like to thank ISA Pudhukkottai for giving me this opportunity, and Dr. Meenakshi Sundaram sir. So the topic that I would be discussing is post-transplant patient who would be posted for a transplant surgery. Orthotropic liver transplant is the standard of treatment for any end-stage liver disease. Nowadays, because of the increase in the success rates of liver transplant, better management, there is better survival of these patients, and hence there is an increased number of such recipients who present for other surgeries. So, what kind of surgeries do they come for? It may be anything. In one particular study, it was found that majority of the surgeries that they presented for was for abdominal surgeries such as incisional hernia. The others included gynecological, urological, orthopedic surgeries. It had been found that about 10 to 15% of post DDLT and 15 to 40% of post LDLT patients presented with biliary strictures requiring ERCP. So, what kind of anesthesia could be given to these patients? It is safe to give general anesthesia or regional anesthesia or even pseudoanalgesia, that is sedation. So what is different in a post-liver transplant recipient from that of normal? One, there's a very high risk of infection in these patients because they are under immunosuppressive therapy. Apart from that, there are adverse effects of the immunosuppressive agents that they are being given, and they have some drug interactions with certain drugs that we use generally. There is a high risk of rejection perioperatively, rejection as in liver, the received organ. Also, there are other organ dysfunctions that are associated with cirrhosis, such as hepatorenal syndrome, hepatic encephalopathy, hepatopulmonary syndrome, cardiomyopathy, as elaborated by Dr. Aditya. So, infection and rejection are the are highest risk for mortality perioperatively in these patients. Now, coming to infection, these patients, as I've already mentioned, are on immunosuppressant therapy. So, and infection doesn't usually present as it does typically with leukocytosis in normal patients. So one has to have a keen eye for infection in these patients. Regular other, if there is no infection, regular broad spectrum antibiotics can be used. Antimicrobial coverage need not be expanded to include atypical or opportunistic organisms as long as active infection with such an organism is not present or suspected. But if there is suspicion of infection with fever or deterioration of the patient, then we look for CRP trend, procalcitonin trend, radiological tests, microbiology tests, and blood cultures. Immunosuppressants. What are the immunosuppressants used? They are calcineurin inhibitors such as cyclosporin, tacrolimus, corticosteroids, antimetabolites such as azathioprine and mycophenolate mofetil, antibody-based therapies, monoclonal or polyclonal, including anti-thymocyte globulin, anti-lymphocyte globulin, mTOR inhibitors. So, what are the effects of these immunosuppressants? The adverse effects: pancytopenia, hypertension, renal dysfunction, interaction with anesthetic drugs, and hyperglycemia. We will deal with these in detail. So, as we can see, cyclosporin and tacrolimus, they tend to cause hypertension, and diabetes, neurotoxicity, renal insufficiency. It constricts the afferent renal arteriole, which leads to renal insufficiency. In addition to this, there is decreased urine output, increased retention of sodium and water, leading to hypertension. How is diabetes caused? There is decreased insulin secretion because there is interference with mitochondrial function in the beta pancreatic cells, inhibiting insulin release. In addition, there is insulin resistance and decreased uptake by adipocytes and insulin stimulated GLUT4 translocation. So there is hyperglycemia, that is diabetes. Neurotoxicity could range from anything between mild tremors to headache to psychosis, seizures, and encephalopathy. So these drugs have been found to reduce the seizure threshold, hence one has to be very careful. Steroids have been found to cause anemia, leukopenia, same with anti-thymocyte and globulins. In addition to this, they cause thrombocytopenia. So when one is considering neuraxial blockade or regional anesthesia, in such patients, one has to be very careful. Mycophenolate mofetil also causes diabetes, hypertension, and neurotoxicity. Monoclonal antibodies have been found to cause anaphylaxis, fever, in addition to leukopenia. Drug interactions of cyclosporin and tacrolimus have been elaborated here. The action of benzodiazepines is prolonged in patients receiving these drugs, and so it is better to use it with caution or reduce the dose. Antibiotics such as erythromycin, metronidazole, norfloxacin, and levofloxacin increase the dose of calcineurin inhibitors. Cardiovascular drugs, antiarrhythmics such as amiodarone, cause inhibition of CYP450, which is required for metabolism of calcineurin inhibitors. So the levels of these agents increase. Also, as we have seen, there is QT prolongation, which is present in cirrhotic patients. In addition to that, CYA and TAC increase the QT interval, and some drugs, some antiarrhythmic agents, as we already know, class 1A, 3, would increase QT interval, which could lead to torsidy pointus. So one must be mindful of this. Directly acting anticoagulants concentration is increased by cyclosporin and TAC. Oral hypoglycemic agents increase the cyclosporin levels. Metoclopramide causes increased gastric emptying, and these calcineurin inhibitors are absorbed from the intestines, so their bioavailability increases. The other drugs such as omeprazole, lansoprazole, octreotide, cimetidine, ranitidine inhibit metabolism, hence they increase the drug levels. These could also cause renal dysfunction and QT prolongation, hence one has to be careful. NSAIDs is a big no in cirrhotics or post-transplant patients. They increase the TAC and cyclosporin level and also could cause renal dysfunction. Coming to anesthetic agents, as per se, isoflurane decrease the clearance of oral cyclosporin. Apart from that, benzodiazepines have prolonged action, which I've already mentioned. Opioids, through mechanisms unknown, cyclosporin has increased analgesic effect of fentanyl. Muscle relaxants, vecuronium and pancuronium, the longer acting muscle relaxants, their action is further prolonged by cyclosporin and tacrolimus. Hence, one has to avoid these and use shorter acting muscle relaxants. Thiopentone, propofol, etomidate, local anesthetics are not affected in patients on immunosuppression. So why are we so worried if there is an increase in the cyclosporin or tacrolimus concentration? So a therapeutic serum level is to be maintained of these drugs. If there is subtherapeutic concentration maintained, there's a very high chance of rejection. And if it is supratherapeutic, that is, there is increased immunosuppression, then there's a high risk of infection. So a steady state is to be maintained and it's essential. It also reflects upon the liver function. A steady state, if maintained, shows that the liver is recovering well. Presence of rejection, it's one of the dreaded complication in a patient post transplant. It could occur in the first few months after transplantation, but can occur, it's most likely during the first few months, but it could occur at any point of time. So we need to know the signs of rejection to pick it up at the earliest. There could be an increase in bilirubin or liver enzyme levels, and there could be coagulopathy. These are the first early signs. There would be increased lactates, metabolic acidosis, hypoglycemia, hypocalcemia because there is decreased degradation of citrate, decreased urine output, hypothermia. The liver is one of the largest organs. It has stores of glucose and it helps in temperature regulation. Hence, we see these signs. And there would be no improvement in hepatic encephalopathy or renal dysfunction, and the patient worsens. The hemodynamics also worsen. So, the definitive diagnosis of rejection is by liver biopsy, and treatment is by high dose of steroid, which is also called pulsed steroid therapy. Now, coming to anesthesia management of these patients, preoperative assessment, we would gather normal history like any other patient, history of presenting illness, past medical history, surgical history, the personal history. Apart from that, one should look for signs and symptoms of chronic immunosuppressive therapy, which would cause, as I've already elaborated, diabetes, hypertension, epilepsy, renal dysfunction, lymphoproliferative disorders. This is one other thing that chronic immunosuppressive therapy would cause, and adrenal insufficiency. So the general physical examination would include pallor icterus, cyanosis clubbing, lymphadenopathy, edema. In addition to that, we look at the vitals of the patient. Dr. Aditya has elaborated about the need for to do so. Then, apart from that, we look for signs of hepatic encephalopathy and we look for ascites. And also, we look for signs of rejection. If rejection is present, then these patients have to be urgently managed. Their immunosuppression has to be increased, else their mortality is high. We also look for signs of infection. Coming to airway, how is airway affected in these patients? Cyclosporin causes gingival hyperplasia, which could cause increased risk of bleeding. There's increased risk of aspiration because of delayed gastric emptying and gastropathy in these patients. Like I already said, lymphoproliferative disorders could occur in 3% of these patients, and growth may compromise any part of the airway or mediastinum, causing life-threatening airway obstruction. So it can occur in many sites, tonsils, stomach, and mediastinum, but it's mostly seen as palpable lymphadenopathy. If lymphoma is suspected or proven, then the patient has to be evaluated further: chest CT, abdominal CT, a bone marrow biopsy, an oncologist and a hematologist opinion will have to be sought before one considers surgery. Now, if the surgery if it suits the surgery, then oral intubation should be preferred over nasal intubation because the nasal flora could contaminate and could lead to infection. Investigations. So one has to plan the investigations based on the surgical procedure, and the patient's condition and hemodynamic stability. So routine investigations would include complete blood count, RFT, serum electrolytes, liver function tests, and coagulation profile, the heart ECG, and 2D echocardiography. These patients are usually evaluated extensively for liver transplant, so a look into those details would help us. In addition to that, a chest radiography. Further evaluation based on patient's condition. Preoperative optimization would include a strict glycemic control because these patients are on corticosteroids, and oral cyclosporin has to be given 4 to 6 hours before the surgery to maintain therapeutic blood levels. Other immunosuppressants have to be continued. Stress ulcer prophylaxis is essential because these patients are prone to stress ulcers due to surgical stress, corticosteroids, and drugs such as mycophenolate mofetil. Intraoperative management, informed consent is to be taken. Monitors include standard ASA monitors. Invasive monitors may be based on the discretion of the anesthesiologist. It depends upon the patient's comorbidities, hemodynamic stability, and the type of surgery that is planned. Invasive monitors would include IBP, PA catheter, and a central venous access. There is no contraindication for general anesthesia or liver anesthesia, provided liver and kidney functions are normal. It is important to note that the titration of the drug is to be done to the desired effect because the effect may not be predictable in these patients. Strict asepsis has to be maintained. Supplemental stress dose steroids are not routinely recommended, however. One should avoid hyperventilation. As already mentioned, cyclosporin and tacrolimus decrease the seizure threshold, so these patients are prone to seizures. Maintain hemodynamic stability, which would help maintain hepatic perfusion. Early extubation is as per ERAS protocol. IV anesthetics. So, what IV anesthetics could one use? So, it depends upon the patient's hemodynamic status, the drug's cardiovascular effects, and the pharmacokinetic properties. Benzodiazepines and barbiturates are to be avoided. Propofol can be used, it is safe to use. However, one has to consider the cardiovascular instability that it causes. Etomidate is also safe to use, but one has to bear in mind that it causes adrenal suppression, and these patients are already having a suppressed adrenal gland because of chronic corticosteroid use. Ketamine is metabolized by cytochrome P50, P450, and its effects are prolonged in the presence of hepatic insufficiency. Inhaled anesthetics, we all know halothane is to be avoided because it causes halothane hepatitis. Apart from that, there is no significant clinical advantage of or disadvantage of one inhaled anesthetic over the other. So it is safe to use isoflurane, sevoflurane, or desflurane. Avoid nitrous oxide because these patients are already anemic, and nitrous oxide tends to cause bone marrow suppression and megaloblastic anemia. Muscle relaxants, we have already seen that their action is prolonged, hence it's prudent to use shorter intermediate acting muscle relaxants. Post-operative care, depending upon the type of surgery, the patient's condition, the comorbidities, and how the patient is after the surgery, the patient one takes a call if the patient has to go to an intensive care unit or post anesthesia care unit. Whether one has to try and reduce the incidence of delirium by minimizing opioids, speed extubation, follow ERAS protocol, early ambulation, and physical rehabilitation. Analgesia, opioids are safe to use. Paracetamol is the safest. Avoid NSAIDs because of incidences of risk of gastrointestinal hemorrhage, nephrotoxicity, and hepatic dysfunction. Immunosuppressive therapy should be continued during the perioperative period, and daily monitoring of steady state cyclosporin or tacrolimus blood levels is recommended. One has to pay increased attention to the preload status, renal function, and prevention of infection. So, to conclude, orthotropic liver transplant patient can undergo non-transplant surgery without postoperative graft dysfunction if hepatic perfusion is maintained with appropriate anesthetic management. When hepatic and renal functions are within normal limits, the use of any anesthetic in patients with a transplant history is not contraindicated, be it regional, be it neuraxial, or general anesthesia. These are my references. Thank you.
Thank you, Dr. Prajwala, for the nice elaborative presentation, enumerating all the delegates who are attending this. They might have got a clear idea what to look for and how to manage a patient who is post-transplant, post-liver transplant, and has come for any other surgery, or what procedures they are likely to come as a part of their continuous liver disease. So I don't see any more questions over here, but I have few questions for all of you all. If the time permits, we'll quickly take. Dr. Aditya, I have one question for you. Can you quickly elaborate on the importance of bubble echo, number one, and what in
Answer.
Hello?
Yes, sir. And
And what primarily in ABG we have to look for when we are thinking about hepatopulmonary shunt?
right. So when in the preoperative anesthesia checkup, when we see a saturation lower than 96, we should have a higher suspicion of ventricular vent ventilatory oxygen VQ mismatch, and there we should get a bubble echo done. Now it's the agitated saline which is injected while doing a transthoracic echo. Here, if the bubbles are from the right side appear to the left side of the heart within 4 cardiac cycles, that means there is some intracardiac shunt which is present. For example, ASD or a VSD. If they appear more than 4 cycles, then there is a probability of extracardiac shunt. Now, if the cycles are more than 6, it is sure that there is some pulmonary shunt which is present. Now, what do I mean by pulmonary shunt? There is the perfusion is happening in that area, but there is no ventilation, and hence oxygenation is hampered. The bubble echo is unequivocal if there is appearance of bubbles within 4 to 5 cycles. So that's where the role of further advanced state tests comes like Muga scan, where radio-labeled albumin is used to unmask presence of any intrapulmonary shunt. Now, these are physiologic shunt. That means there is vasodilatation which happens because of the hepatic disease, and there is decrease in the oxygenation, and hence VQ mismatch. Now, to corroborate clinically, as I said, there would be decrease in the SpO2. Now here, arterial oxygenation, or big A, PA, to be found out with the help of universal gas equation, and when we know the FiO2 which the patient is at, we can find the P, partial pressure of alveolar and partial pressure of arterial oxygenation, and we can find out the gradient, that is P big A minus small a. So P, the arterial alveolar oxygenation gradient can be found out. Here, it is important to find this thing out because the classification of HPS depends on that, whether it is mild, moderate, or severe. Severe HPS in itself is a contraindication even for transplantation surgeries in certain cases, but there are isolated case papers where they have transplanted successfully and there is reversal of HPS in patients with PaO2 of even as low as 28. But post-operative management, intraoperative use of nitric oxide, etc. depends on these cases, and hence our preparedness for transplant or non-transplant surgery is dependent on this particular test.
Thank you. So one question for Dr. Greeshma. Dr. Greeshma, are you there?
Yes, sir. Yes.
So, do you think Rotem and TEG both are equivocal and equally good, or you would recommend one over the other? If you're recommending one over the other, which one is better then?
Rotem over TEG.
Okay, fine. Dr. Prajwala, one question for you.
Yes, sir.
Would you recommend, or is it recommended to have tacrolimus level assessed for any patient coming for non-liver surgery or maybe liver procedure for anesthesia management after transplant?
Yes, it is recommended, of course, to monitor the levels of cyclosporin or tacrolimus, because as I've already mentioned, a steady state needs to be maintained. If there is an increase in the drug levels, then it could lead to infection and rejection if there is a decrease in the levels.
Yeah. Thank you so much. Any other questions, Meenakshi sir?
Sir.
Dr. Emma? Okay.
So can I conclude the session today, sir?
Yeah, so I'll just thank all the speakers and congratulate them for their wonderful presentations. I think this is a very good nutshell for all the people who had most of the questions. I think they have been answered, and most of the slides were the ready reckoner troubleshooting slides, wherever anybody can, if has any question later also, and if they have this snapshot of these slides, probably they'll get the answer immediately. So I think a very nice conclusive presentation from all the speakers. Over to you, Dr. Emma.
Thank you, sir. Good evening, everyone. I thank you all for your participation in today's episode on liver transplant, the incidental surgeries, which is our 20th episode in the Puthukkottai Bhudhan series. Our sincere gratitude to our academic chairman, Dr. A.L.M. sir, for guiding us through the series. I thank Dr. Greeshma Somnath, Dr. Hiranandani Hospital, Research Center, Mumbai, on the topic on thromboelastogram. Thank you, ma'am. I thank Dr. Aditya Anil Prabudesai, Gleneagles Hospital, Mumbai, your topic on cirrhotic patients posted for non-liver transplantal surgeries. Thank you, doctor. I thank Dr. Prajwala Kaushik, Kokilaben Dhirubhai Ambani Hospital, Andheri, Mumbai. Ma'am, thank you for the presentation on liver recipients posted for non-liver surgeries. Thank you, ma'am. And finally, I thank our moderator, Dr. Ujjwalraj, Dudhedia, Dr. Hiranandani Hospital and Research Center, Mumbai. Sir, thank you for guiding us today in today's episode. Thank you, sir.